Welcome to Talking Meds on the PrescQIPP podcast, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill. Hello and welcome to the latest episode of Talking Meds. I'm your host, Jonathan Underhill. Today we're going to be continuing our series of podcasts called Caring About Medicines and Care Homes with Jonathan and Sundus. So I'm delighted to be joined by Sundus Jawad again. You'll remember Sundus from last time. She works for NHS Frimley, has over 25 years experience working closely with GP practices, care homes and other providers. And we're going to talk today about, things that are challenging Sundus or have been challenging her over the course of her career. So Sundus, how many care homes pharmacists are there out there in the NHS? Are there loads of you, or are there just a few of you? What?
That's a really good question, Jonathan. I really don't know. But what I do know is that there's definitely been an increase in the number of pharmacy professionals working with care homes over the last, I would say, 8 years, probably since NHS England put in the funding for those MOCH roles, medicines optimization in care homes roles, and the CPPE MOCH training pathway. I think, if I'm not mistaken, approximately 350 people completed the MOCH training pathway. So we definitely have at least 350 pharmacy professionals who were trained up to work with care homes.
It's certainly a lot more than when I worked at the National Prescribing Centre about 15 years ago. We used to invite care homes pharmacists along to our events, and there were really just a handful of you, but it sounds like that network has grown significantly since that initiative. So how do you all stay in touch then?
Yeah, that's a really good question. Well, some really exciting news, recent news, is that we now have a national pharmacy care home faculty, which I think you did introduce in one of the earlier sessions that I was elected to chair. So real privilege for me, great opportunity because it's something I'm passionate about. But what a great initiative, a national pharmacy care home faculty for all care home pharmacy professionals to be part of. And the aims of the faculty is really to be a representative voice for all pharmacy professionals working with care homes. There's going to be support with education and training, opportunities for research in care homes, lots of opportunities for advocacy, and obviously lots of networking. That's the plan with the faculty. And we are very much in its infancy at the moment, but we are working towards developing a credentialing framework. So people who may not have done the CPPE MOCH training pathway, an opportunity for them to do the credentialing through the National Pharmacy Care Home faculty, and, to be recognised for the work that they're doing in care homes, etc. So yeah, lots of networking now, lots of opportunities through the faculty. Prior to the faculty, we were networking really through email or through opportunistic kind of ad hoc means. But the faculty hopefully is going to change all of that. So anybody who is listening, who is interested, please do look up the National Pharmacy Care Home faculty membership details. It's only a small fee to become a member, but we are all working to make sure that it's going to be a membership worth having.
And we'll put a link to how you can find out more and join that in the show notes.
Absolutely.
There. So what sort of examples can you give where this sort of networking has been helpful, or perhaps would have been helpful in the past for you?
Yeah, I mean, I suppose when I started with care homes over 20 years ago, I really did feel very, very much alone. In fact, I don't think I knew any other care home pharmacists, and it would have been nice to just be able to email someone or pick up the phone and just say, look, I've come across this, I'm a bit concerned, I don't know how to kind of approach it, whether it and some of the topics are quite complex and are need to involve other people from the multidisciplinary team. You might need to work with safeguarding, you might need to work with SLT or a specialist nurse, or with specialist teams like LD teams. And sometimes you needed their contact details, or maybe just some advice on, have you seen this scenario before and how did you manage it? So those kind of situations, yeah, it would have been really helpful 20 plus years ago to have somebody at the end of the phone or at the end of an email to say, oh yeah, don't worry about that, go to this resource, or we did this, why don't you try this? And that's kind of why I started a email network recently, just before the faculty actually. So that's been going for about 3 years, where we have over 100 pharmacy professionals, and we just support each other with queries. Obviously, the National Pharmacy Care Home faculty now has a Telegram group where members can all ask those kind of questions and get immediate support, even later during the night is what I'm finding. Most of the questions are coming through, but it's a really good kind of opportunity to be able to ask colleagues who might be more experienced or have differing experience to be able to support.
Brilliant. That sounds like a really interesting initiative. There's nothing worse than feeling lonely and unsupported in your career, and this is a great opportunity for care host pharmacists to stay in touch with each other and, as you say, support each other. And yeah, ask questions, because the group will have the answer usually, or at least be able to help you a little bit. So we were talking earlier, weren't we, about some of the projects that you've been working on over the last few years, and you mentioned something about the importance of hydration in care homes residents. So just tell us a bit more about the projects that you've done around ensuring adequate hydration for residents.
Yeah, so that was one of the kind of more, I suppose, important projects, or one that got probably quite a lot of recognition nationally. Whereas actually there are other projects which I think, I'm probably, I feel they should have probably got more recognition. But again, going back to that lack of network and lack of, not knowing who to share with, because you don't know who else is doing similar work in care homes. So, and a good example of that would have been the work that I led on a project looking at reducing inappropriate prescribing of antipsychotics in dementia. And, I wish that had been shared wider. But again, because it was years ago, I think it was 2012, 2013, we didn't have the networks to share at that time. But the hydration project, which we did, when did we start that? Probably 2016, and we finished in 2018, 2019 maybe. Lots of opportunity to share the learning from that. I was lucky that it was also supported by the then Academic Health Science Network, which is now the Health Innovation Networks. And it was Oxford, which is our local Health Innovation Network team that reached out to us and said, look, we've got some ideas and funding for projects. What do you think we could do with AKI, acute kidney injury, and we want to do something in care homes? And I thought, this isn't. It came to me because I was the care homes pharmacist and or the pharmacist supporting care homes, and I thought, that's going to be a difficult one to do in care homes. AKI is a very acute condition, and they'd probably be in hospital before that gets diagnosed. I don't think that's a good one. But I said, what would be good is looking at urinary tract infections. Every time I go into a care home to review someone, and it was summer actually when I got asked this, and I thought, last week I was in a care home, I've gone back this week, and 6 people have been put on an antibiotic for a UTI. And I thought, it's the weather, that we had a bit of a heat wave that year, I think, and I thought there's something about them, these people are vulnerable. Care home residents are vulnerable, and just a small heat wave or an increase in temperature can have a huge impact on them if they're not supported in the right way. So I thought, why don't we look at that? And then I showed them some of the data. We were lucky to have a care homes dashboard, which we still use to today actually, which shows hospital admission rates from each of our care homes. And that was kind of what informed the deciding factor as to whether or not we were going to go down the route of a hydration project in care homes. Because what we found was that actually there were a number of care homes where there were higher admissions into hospital with UTIs than others, and it was the most common reason for hospital admission at that time. It's now, I think, number 3 on our dashboard, so it's definitely gone down, and numbers of UTI hospital admissions have gone down since the project. But that's how we kind of decided to go down that route of hydration project in care homes. And had we had a network, had we had others to reach out to or knew of others, I could have reached out and said, oh, anybody else done a project on hydration? It would be good to know what you've done, what you've tried, what's worked, what hasn't, etc.
So what did you do then, Sundus, for the project?
So for the project, what we did was we introduced some training around why hydration is important, what a UTI is, what acute kidney injury is, what medicines can increase the likelihood of dehydration, or can be or there are increased risks with their use with dehydration, why hydration is important and how to improve hydration. And then obviously information about this vulnerable group of patients, particularly those with dementia who, we know as people age, they lose that sense of thirst and, feeling hungry. They lose those senses, or they diminish with time. So they might not ask for, if somebody's got dementia, they might not be able to ask for a glass of water. They might have a physical disability. They might not be able to get up and go and get a glass of water. So all of these things kind of included in the training. And then staff were trained to conduct 7 structured drinks rounds each day. And they were quite exciting drinks rounds. So they had to decorate their trolleys, offer different drinking utensils, different types of drinks. And we measured the number of UTIs that required hospital admission, or the number of UTIs that required antibiotic prescribing, but the residents stayed in the home. And we did this using a safety cross, which I had come across actually from a nurse who I'd met in a care home years ago, and they were monitoring pressure ulcers, and they used a safety cross to look at the number of days between pressure ulcers. So I thought that we'll use a safety cross to measure the number of days between the incidences of UTIs. And what we wanted to increase the number of days between UTIs. And I think one care home had a UTI on an average of 1 every 10 days, and it had gone to something like 1 every 180 days. Which is fantastic. So that indicates that the incidence had gone down.
Brilliant. So for me, there's a couple of things that jump out at me. It's about education and training and raising awareness of this being an issue in the first place. It's something that you can do, care home staff can do something about quite easily, actually, once they're made aware of it. And the other thing was you brought an element of fun to it by creating some sort of fun around the drinks rounds and making a thing of it. And of course that will then engage the residents, and they'll look forward to it, and makes their days pass a bit more joyously. I remember the other thing we talked about before is, I think you had some examples of people who were serving tea to residents, and the tea just wasn't very nice. So they were buying either cheap tea bags, or not putting sufficient milk in and stuff like that, but actually a little bit of investment in buying some decent Yorkshire tea, or clearly other tea bags are available, but some nice tea for the residents, and actually making it to their taste, rather than not too strong, not too weak. And that's obviously going to, if it's palatable, then residents are more likely to drink, and that saves you time down the line, doesn't it? Because if they then don't get a UTI, or they don't get dehydrated, then that causes you less problems for the future. It's that thing about failure demand again, isn't it, that we talk about quite a lot, where you don't do things properly in the first place, and it creates a whole load of work for you down the line. So I think this is a great example of a project. So what sort of things did you see as a result of this then, Sundus?
Yeah, so what people in care homes were reporting about, the people that were conducting the project, the people that were helping us with the project. One example was they had a gentleman who was in a wheelchair, and actually he wasn't really keen on drinking much, because he feared needing to go to the toilet, because every time he needed to go to the toilet, he'd have to, there was a whole palaver of him having to be taken out of the wheelchair and supported and helped and then put back. So he avoided drinking, was his solution. But then when he had some information through a leaflet and a one-to-one with our medicines optimization dietitian in our team about the importance of hydration, we gave him a diary, a kind of a diary to keep for 1 week of how much he drank. He realized maybe he wasn't drinking enough, and then 6 months later he was out of his wheelchair and fewer UTIs. So that was a positive one, because he also it empowered him to help himself. And that was in a residential care home. In a nursing home, what was really good is that we saw obviously less antibiotics being prescribed because fewer UTIs were being reported. We also improved good practice by explaining to care home staff that dipstick testing everybody's urine on admission or every week is not really good practice. Some care homes were doing this, and it was such a waste of their time. And also, they weren't familiar with asymptomatic bacteriuria, which is, urine is a dirty substance. We will find bacteria in urine. It's whether or not it's a UTI. So that training around how to clinically diagnose or correctly diagnose a UTI was really important to them. So we had improved clinical practice, improved diagnosis, and antibiotic treatment being used where it was appropriate. So yeah, it was a really good project. I really fond memories of the project, and the work continues. You said it was such a simple idea about decorating a trolley and giving people the right utensils, bright cups, etc. That or different cups to drink from. But that's what's made it sustainable. We have care homes now that decorate the trolley as an activity, and it's just it's brought back fond memories. Do you know, in that project, I was given £150. That's all we had to do the project. And you think, what do I spend £150 on? And in the end, I decided to spend it on colourful cups because, as I think I've mentioned before, 20 years of experience working with care homes, the cups that I've been offered grey murky tea in, I'm like, thank you, but I'll miss out on it this time. And water, when they've offered me water, they've come in these, really old cups and glasses, and you think, oh, they don't look very appealing. So I thought, let's give them some nice colourful cups. And we know that colour particularly is important for people with dementia. So that's where we started. And it was a kind of a thank you as well, to say, look, thank you for trying to look at this issue. And that's, I think, why it was so successful. It was working with them to develop something together. So co-production, and also it was easy. It was something that was simple, that they could follow through and also adapt to make it, suit their own care home. And that's why we've been able to sustain the numbers and the progress in Frimley.
Absolutely. Again, it's an example of something on the surface of it looks like a really simple intervention, but actually there's actually quite a lot of complexity to it as well. Because as you say, you worked with people on this. If you work with people, people are more likely to come alongside with you. You said it was adaptable, so people could adapt it to their own care home or residential home situation, and you made it fun, as I say. I was going to ask you how much budget you had for this, but it sounds like you didn't have much. And again, so cost is not a barrier here for people to do this. It just requires a little bit of dedication and a bit of purposefulness, if that's even a word. I don't know. The other great thing that struck me about this is that this fits with the antimicrobial stewardship issues that we have in care homes and residential homes, doesn't it? We know that there are higher levels of antibiotic prescribing in care homes than there are in other parts of the community. and I think your point about screening urine for bacteriuria, where people don't have symptoms, people who, as they get older, will have bacteria in their urine. Whether or not that's causing an infection or not, probably not. So it's about being aware of that as well. So I think that there's lots in this. As I say, sounds like quite a simple thing to do. It just requires a bit of effort and a bit of thought from people. So presumably, did you publish this, Sundus? Is it available for people to see? Are there resources that people can share?
Yeah, absolutely. So NHS Improvement at the time did develop it into a toolkit. It was also published in the BMJ Open, so I'm happy to share that as well. And it has a whole webpage dedicated to the project. So it was a patient safety project with all the resources. So anybody out there who wants to replicate this or adapt it in whatever way, I'm more than happy to help. We'll share the details with you, Jonathan, and hopefully people can improve hydration in their care homes and on their patches too.
Absolutely, we will definitely put a link to that in the show notes for this podcast. Sundus, thank you so much for once again sharing one of your great stories with us on a great initiative that you've worked on. I think it's also important that we said at the start about the people who work in care homes, perhaps thinking about joining the National Pharmacy Care Home faculty. We'll put a link to that in the show notes. Please don't feel as if you're not supported out there. You are. There are lots of people like you who work in care homes now, and working together has to be a good thing to do, doesn't it? Okay, guys, thank you for listening, and we'll see you soon for the next episode of Talking Meds.